That's not true, Duncan. Hello and welcome, everybody. We have a small contingency here in person, but if you're around and in the Mission Bay area, we do have sandwiches in the Open Door auditorium, so I hope you will join us. And if you're joining over Zoom, welcome. I think this is the part where Duncan says I should always say the same thing over and over again. There's the land acknowledgement, but I always like doing it, even though sometimes it might feel very tokenistic to do it. But I do actually think that Pediatric Grand Round is a place where we try to build community and honor community. And that is so in the tradition of the traditional custodians of this land, the Ramaytush Ohlone people, that it is very appropriate to acknowledge that we sit on the land that they call theirs. I also, at the beginning of this Grand Rounds, want to announce that this is the last Grand Rounds as we know it. Not that we're going to do anything so dramatically different in the next year, but we are joining the Frontiers in Pediatrics series with our Grand Round series to really try to get people from sort of the really sciencey part of our community and the people who are not so into the sciencey part of our community together. And we hope that there will be a lot of cross-pollination and people will come to the broad variety of topics that we're presenting, and very grateful to the new Pediatric Grand Rounds Planning Committee for helping us put this all together. With that, and without further ado, I am going to introduce our speaker. Not that these slides want it forward, but maybe they do. Nope. There we go. So our speaker for today is Dr. Suni Kaiser, who is a professor of pediatrics and epidemiology and biostatistics at UCSF. She also is our division chief for the Pediatric Hospital Medicine Division and chair of the Pediatric Research and Inpatient Setting Network, which is a national and the National Steering Committee member for the American Academy of Pediatrics, Pediatric Acute and Critical Care Quality Networks. She's also a volunteer consultant to the Children's Hospital Association and an NIH-funded health services researcher. She's really very instrumental in lots of work related to quality improvement at our institution. But today, I think, is mostly going to talk about her research program, which includes research focused on accelerating the pace at which evidence is broadly implemented into care to improve care quality, leveraging quality improvement efforts to advance health equity, and growing and synthesizing the evidence base around care of common diagnosis among hospitalized children. She not only locally but also nationally has really is recognized for her work in doing really impactful QI work, and we're so grateful that she has accepted the invitation to come join us here today.
Okay. Oh. There's the cable. Okay, this cable's finicky, so if the screen goes out, let me know. Thanks again for joining today. And I know Sandrine's watching the Zoom. It's a small group, so if questions come up, just interrupt me along the way. But as mentioned, I was going to chat with you all about a new kind of concept, an emerging, I should say, concept in quality improvement called EFQI, or Equity Focused QI. I have no disclosures. And broadly, the objectives for this time, the next 30 minutes or so, are to review kind of the evolution of quality and safety efforts in healthcare, to understand some core concepts in equity-focused QI, and then ultimately to identify some ways to integrate these concepts into your own work. So we'll start with this review. This is a timeline that some of our residents are familiar with. I give a similar version in sort of broadly giving folks an overview of the evolution of quality and safety efforts in healthcare, and mainly to set the stage that they're relatively new. So prior to really 2000, 1999, the general public, as well as those within the healthcare sector, largely assumed that if you walked into a healthcare facility, a clinic, a hospital, et cetera, that you are getting good care, that the long kind of training processes we go through, credentialing, continuing medical education, certifications, et cetera, ensure that for your problem was going to get diagnosed, evaluated quickly, and you would get the most evidence-based treatment. And because of those broad assumptions amongst the public and those within the healthcare sector, there wasn't really a business case, infrastructure, or research or work on quality and safety at a broad scale. And what I mean by the business case is if there was money to be prioritized or invested, it was usually put into expanding services or staff or infrastructure and not measuring or understanding quality or safety. But then in 1999, the Institute of Medicine put out a report that some of you may have heard about somewhere along the way in your training called To Err is Human. And it actually quantified very powerfully huge gaps in the US healthcare system, gaps in quality, ways in which it was unsafe in preventable ways, inequitable in both access and outcomes, and came at an incredibly high cost relative to other sort of economically comparable countries. And a poignant sort of stat that came out of that report was that upwards of 300 patients in healthcare facilities in the US were dying every day from preventable causes. So basically, like a whole Boeing 747 worth of people crashing every day that could be prevented. This report really just quantified the problem, didn't do a lot in terms of pointing in the right direction as to next steps. But around that time, and leading up to this, many people were thinking about this, and the IOM did put out a follow-up report 2 years later called Crossing the Quality Chasm, which started to outline some key steps to achieve better results, including more meaningful use of information technology, really defining more clearly for clinicians our most cutting edge sort of evidence-based practices, and reforming payment and policy to support use of them. They also, around this time, really crystallized the targets we should be working towards as a healthcare system, including safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. And I'll talk a little bit about kind of the evolution of each of these domains high level over the last 20-ish years or so, but I would argue that equity is probably the least developed in terms of the science of sort of interventions to address this within the healthcare system, and how best to implement and scale those things as compared to these other domains. So most of you hopefully are familiar with these basic kind of QI tools that have been used really widespread to improve efficiency and timeliness, mainly some on effectiveness as well. So plan, do, study, act cycles, where you understand a given kind of clinical workflow problem. Plan little tests of change in your workflows, and then see how they work. And on the right, I have sort of a Pareto chart where you sort of think about what's the biggest bucket contributing to, usually again, an efficiency or timeliness problem, and focus on those sort of biggest issues at a time. So these kind of quality improvement tools, lean methodology, Six Sigma, these have been widely adopted across the healthcare sector. Again, mainly with a focus on improving sort of 2 to 3 of those IOM domains. Some of you may be familiar as well with, in the pediatric hospital space, solutions for patient safety. Safety is another one of these realms where we've made a lot of progress in the science of and the infrastructure to improve in this area. So Solutions for Patient Safety is a consortium of children's hospitals that roll out bundles of interventions. Commonly in the safety world, this involves like safety or procedural checklists and workflows to prevent preventable harms. So some examples of their results here, they've started sort of aggregating again over the last 10, 15 years, the work they've done on things like unplanned extubation and catheter associated UTI. And they've really, again, the scale of this work across many, many hospitals is impressive and is very much around kind of rolling out education and evidence-based protocols, pathways, and checklists to achieve these results. So great results there as well. I mentioned patient centeredness is one of these core domains. With the Affordable Care Act, the Patient Centered Outcomes Research Institute was funded through a tax on insurance companies. And they have really led the way in developing a wide variety of tools to measure patient centered outcomes and evolve the science of how to engage patients and families in research as well. So again, this is a domain that has gotten a lot of attention and focus, and the science and operational efforts around this have come a long way. And then in terms of effectiveness, the National Quality Forum was formed kind of in the early 2000s, again, to define evidence-based best practices and then hold kind of healthcare systems accountable for measuring those and patient-centered outcomes, and then report them out to improve effectiveness of care. So this is a snapshot from obviously our biggest payer of healthcare in the United States, the Centers for Medicare and Medicaid are a huge leader in this linking sort of payment to quality performance and effectiveness. And this is a website that exists that any of us can go on to, type in our zip code, and then get these quality and safety ratings for hospitals that are nearby using this collected and publicly reported information. An important point to make in the graphs I've shown you along the way that'll link to this equity focus of our talk is that all these measures are traditionally and have most commonly been reported in aggregate. So for like all the patients you serve, not looking at disparities or particular subgroups. So again, sort of closing out that very, very big picture review of kind of the evolution of quality, safety, and equity in healthcare. There's been a lot of immensely, impactful work again in safety, patient-centeredness, timeliness, efficiency, but equity has been one that has lagged. So particularly in pediatric hospital medicine, sort of my space, we have started over really, I would say the last 10 years or so, trying to understand disparities in pediatric hospital care and quantify them. And they're ubiquitous. So wherever we look, analyses usually are by race or ethnicity or by markers of socioeconomic status have shown disparities in things like the escalation to or need for intensive care, preventable medical errors, length of stay, costs, mortality, readmission which is a marker of sort of inadequate inpatient or follow-up care timeliness of care, family-centeredness, perioperative outcomes, pain control, a lot of disparities in sort of the evaluation for and referral to due to concerns around abuse, and then the use of chemical and physical restraint. So this is just high level highlights of areas where we see disparities as we've started to look in more recent years. I specifically have done some work around preventable medical errors, hospital readmission, and perioperative outcomes with some collaborators that I'll highlight here. So we used a national database, partners at Children's Hospital Association and Children's National, and I looked at disparities in preventable safety events, and these are all ones that are publicly reported. And so most hospitals are mandated to report this data, and so they exist at this kind of national level. So again, things like central line associated bloodstream infections, um, catheter associated UTI, things that we know we have interventions and ways to prevent, and yet they still happen. And as I mentioned, they've been a major focus of safety efforts for upwards of 2 decades now. When we looked at how rates of these compare by race or ethnicity, we found that of the 7 studied preventable safety events, that Black and Hispanic patients had significantly higher rates in 5 of those, with the largest disparities in postoperative sepsis and postoperative respiratory failure. We also looked at measures of socioeconomic status using primary insurance as a marker of household income as a proxy for that, and found that children on Medicaid had significantly higher odds of 4 of these 7 events. And then often there's a critique in these types of analyses about intersectionality, and that it may actually just be one driver that's manifesting in multiple ways across multiple groups. But we found that these disparities by race, for instance, persisted even amongst privately insured children, which argues that there are structural factors that go across these multiple domains and aren't just confounded, essentially. When it came to readmissions, we did an analysis looking at ambulatory care sensitive conditions. So these are things like gastroenteritis and asthma, where if you have access to high quality outpatient preventive care, you shouldn't get admitted for these conditions, at least you shouldn't have high risk of that. And we compared hospital readmission rates for these by Child Opportunity Index, which is a really cool measure of sort of the global resources by neighborhood that a child has access to. So this is everything from the cleanliness and quality of their environment, to schools, to healthcare access, to healthy food. And it's a really innovative, like, composite index that draws from multiple public sources of information to quantify, again, sort of overall socioeconomic status. And we found that there's a significant difference in risk of readmission for children from the most very low resourced areas of 18.7% compared to the very high of 13.5%. And then readmission, even more than once to the hospital, also, showed that same disparity. So why does this happen? As I mentioned, there's been like decades of really great quality and safety work happening all over the country. And the assumption of all that work is that the underlying assumption has largely been that if we standardize care for everybody, that care will improve for everybody. And in that way, if there is a disparity, it will close. So this is sort of a very simplified graph of how that might look, right? Where I have sort of an examination of language disparity here. And if we had a safety bundle that we were trying to roll out, it may be that English-speaking patients have a higher rate of receiving that bundle at baseline, but the goal of QI is that everybody gets to a higher compliance rate, and that disparity closes over time. And I think that's largely been the assumption of what would happen. But as you can see from the recent data I showed you, that's not what has happened. And as I mentioned, most quality and safety data to date has not looked at things divided by subgroup, has examined disparities at all. So it's looked like this, where we just pool everybody together and we say, has everybody gotten better or not, per 100 patients, et cetera? How often are these things happening? Um, so Don Berwick, one of the founders of the Institute for Healthcare Improvement, has a lot of famous quotes, and this is one of his that every system is perfectly designed to get the results it gets, right? So if you're not looking at disparities and you never know about them, the system was never designed to address them, right? And that is likely the reason that we are getting the results we are. So this is what actually happens in most QI. We know now that that if you don't have any kind of disparity monitoring in place along the way, or understanding that at the beginning, that it does tend to improve care, but just maintain disparities. And so, that delta difference of like 20% less Spanish speaking kids getting this recommended treatment just stays fixed, where they do see improvement, but again, that gap in care stays the same, despite all the efforts and focus and resources we put into these projects. Um, there are a lot of like great thought leaders in this space that I'll go back and just say sort of planted the seed that this is probably what most QI does early in my sort of career in quality improvement. And so towards the end of a big project I did with the American Academy of Pediatrics, we had a wonderful fellow, Sarah Schechter, and I said, Sarah, like, let's see what our project did. Like, what did it help? Did it maintain? What happened? At the very least, we should look at this. So this was a large QI intervention. We rolled it out again with the help of AAP to about 85 emergency departments and inpatient units across the US. We gave them quality improvement coaching, clinical pathways, educational bundles, data monitoring infrastructure around several evidence-based practices. So things in the ER like getting systemic steroids within 60 minutes, getting a respiratory score done. In the inpatient side, using metered dose inhaler early so we could do teaching around that, screening for secondhand smoke. And these evidence-based practices, many improved significantly over the course of this 1 year project. So we saw improvements in timeliness of care, decreases in rate of admission from the ED to the hospital, screening for secondhand smoke. But at the beginning, there were disparities by insurance, with higher rates of ED to hospital admission, longer length of stay, and higher revisits for kids on public insurance. And those unfortunately remained at the end of the project. So again, everybody improved in multiple domains, but the disparities remained fixed. There is an even worse scenario, which unfortunately has been documented sometimes as well, which is that we pour all this effort into quality and safety work, and it actually worsens disparities. So if we see that our intervention preferentially helps our more well-resourced or better performing group than it does others, then we can even widen this gap. And this may seem like highly counterintuitive, but this has been shown in instances where, for instance, in New York, state Medicaid runs quality and safety collaboratives, and they found that their better resourced hospitals were more likely to participate. Their safety net hospitals just didn't have the bandwidth to even be part of the collaborative. So at the state level, the disparities in sepsis mortality actually widened when they looked at disparities alongside these efforts. So, and then the other way in which it happens is when we design interventions really like in partnership with and for and by advantaged groups. And so we don't really get the full lens and degree of incorporation of all the different people that will be serving with the intervention. And so, again, it preferentially benefits an advantaged group. So, as I mentioned, there are a lot of great thought leaders in this space. Jean Raphael, Casey Lyon, Michelle Pina are just a few that I cite here. And they, over the last few years, have put out some really great guidance on core principles of equity focused QI. So I'll go through these in a little bit more detail. And again, we'll talk about some applications of these. So I hope I've already made the case that a core part of this, but perhaps the most foundational part, is that you need to evaluate your quality and safety data through a disparity lens. And this is by no means an easy task. And again, like sort of the science of how to do this is very nascent. And some of the limitations are that we have really suboptimal quality of what we call real data. So race, ethnicity, and primary language data, and as well as other domains we might examine disparities around. And even when we improve systems for collecting that data, there are limitations in sort of how we can truly quantify and assess when a disparity occurs. So again, this is not easy, but at the very least, we should do what we can with the systems we have in place to understand what disparities might exist at the beginning of our interventions and monitor to make sure we are improving and not worsening them. And also, when we do that assessment at the beginning of a project, considering really tailoring our interventions towards the subgroups that are having the worst outcomes to begin with. Another key principle in this is deeply understanding the drivers of disparities. Most of our QI teams and quality teams are just small groups of clinicians. And so they don't necessarily represent the sort of lived experience of our patients, especially groups that are underserved. And so really partnering in our quality and safety work with patients and families, community partners, community-based organizations to understand why they occur. And so what we might do differently in our interventions to address disparities. Implementing evidence-based interventions remains sort of a core that should not be sort of left behind in equity-focused QI. Proven medications, treatments, practices, tools to, remind clinicians what to do when. So some of the core strategies, of course, that you all are, I'm sure, familiar with are audit and feedback, things like PDSA or cycles of change, and engaging multidisciplinary teams, and that should continue to remain a core part of this work. And then, of course, acknowledging that the disparities we see don't exist in a vacuum, and that hospital or even healthcare is a very small part of overall health. And so using the hospital or sort of healthcare encounter as an opportunity to address those larger social determinants of health and connect people to community and other resources to address those is very much a core part of this work as well. So the good news is that with integrating these principles, we can actually achieve very positive change in this space. So Sarah Schechter, who I mentioned, Lucky, who's sitting back there, helped with this scoping review of the literature. Also Adria, who's one of our residents as well. So we did a scoping review of all the pediatric literature in the quality space that happened in hospital settings. So NICUs, nurseries, ERs, inpatient units, a lot of studies. And we first asked the question, how many even looked at disparities? Less than 1%. As I mentioned, this science is nascent and really not a lot of people have been doing it. But we did find 19 studies that examined disparities, and of those, 80% found them. Again, these are ubiquitous almost everywhere we look. And these were mostly, again, by race, ethnicity, or markers of socioeconomic status. But of those 15 studies that found disparities, 80% improved them. So by knowing about them, measuring them at the beginning or somewhere along the way, and having that lens and intentionality right from the beginning, just using normal QI methods that again we know sort of what works and have been using them a long time, the majority led to improvement and definitely not maintenance or worsening, those things we worry about. So our big conclusion in this work was that pediatric QI can definitely be better leveraged to improve disparities if more of these efforts have explicit infrastructure to measure disparities and think about ways to address them. We more recently did another scoping review of the literature. This is with two of our fellows, one of our junior faculty, looking at sort of the more formal integration of quality and equity measurement in hospital settings. So if there's real-time reporting happening at the institutional level. And in the entire, I think we looked at least 25 years back, literature, we only found 9 studies that describe efforts to do this, and all focused on the disparities by race or ethnicity. The majority, again, reported they found them. And again, all this work takes a lot of infrastructure and resources and planning. And so we dove a little bit more deeply into these studies in terms of what facilitated or got in the way of trying to pair, again, quality and equity measurement. And facilitators included broad engagement, high quality data sources, and some multi-center collaborative work to help troubleshoot and share best practices. But barriers were really resources. So lack of sort of staff and data infrastructure to do this, and also a feeling amongst clinicians, which is prominent across, sort of multiple of these efforts, that when they find them, there's sort of lack of ability to address these disparities, both within the hospital, but also linking them back out to the community. So I wanted to close again with some ways, thinking back to those core principles, like what are some ways day to day that we can integrate an equity focus into our quality and safety work. And the first, again, that first pillar was just measuring and detecting these disparities. So this is a screenshot of a report that I've helped the Children's Hospital Association put together, that we are giving back to hospitals to understand what their real, again, their race, ethnicity, language, data quality is. So often we find that the practices in collecting this data are really fraught. People might just assign race or ethnicity, for instance, based on how a caregiver looks, as opposed to even asking the question, especially when there are language barriers. When the question is asked, sometimes folks aren't clear on what the answer choices are. There's all kinds of problems. And when that happens, we'll often find that this sort of data point is either missing or just batched into the bucket of other, which really limits our ability, again, to understand what disparities exist. So standardizing these data collection processes, which we're doing across BCH, there are efforts to do that. Adding more elements like gender, preferred language, reconfirming these, and ensuring that families know why we're collecting them, so that we can improve engagement in this process, is all really helpful. And when we do detect disparities using these data, we would ideally then integrate this into how we prioritize our quality and safety efforts, and understand it across sort of multiple domains. So we're not just prioritize, we largely prioritize our efforts based on kind of regulatory pressures or, peer performance pressure, things like that, but integrating sort of the focus on disparity into that prioritization of where we put our resources. Um, so I'm now leading a sort of a subsequent work focused on improving asthma, pneumonia, and bronchiolitis care in community hospitals. Um, and again, as this science evolves, we're trying to evolve with it. So um, as I mentioned with the prior work I did, we examined effects on disparities at the end. With this, we tried to do it from the beginning. And so as soon as we had enough sort of data on the baseline state before our intervention was going to roll out, we examined disparities across multiple domains by race, ethnicity, primary language, and primary insurance. And we did sort of layered analyses to understand potential intersectionality across these domains. The good news was we found actually no significant disparities in evidence-based practices, but we did find higher readmission risk in children with asthma that were either Black or publicly insured, consistent with those prior studies and larger literature as well. So, having done this earlier in the course of the QI work, we modified things about our intervention to specifically try to address this. So, integrating prescription of inhaled corticosteroids, alerting clinicians as to like which of those are covered locally to make that process easier, thinking about follow up more, doing more teaching to improve self efficacy around MDI administration and things like that. So this project is ongoing, and so we are monitoring again, sort of in real time and at the end, how we do with both overall quality and disparities. Um, and we did not have the time in that project to do this, but I'm part of other work where we're trying to map exactly what it looks like to understand drivers with broader groups. And again, this is more labor intensive work that you need resources and frameworks around how to do. So I mentioned some of the safety disparities we detected in national data. We had the unique ability to, because that was national data, look at hospitals to identify hospitals where overall safety was good, but disparities were bad. And so we'll call that sort of poor disparity performance. And then also a group of hospitals where both safety and equity performance was good. And now we're doing sort of in-depth qualitative work, engaging broader groups at those hospitals, thinking about disparities in post-op respiratory failure and talking to people in the pre-op, operative, and post-op setting to try to understand what the drivers of those might be. We're actually in some of that work using, again, like normal QI tools, like thinking about, again, what are the drivers and potential interventions, but also using broader disparity frameworks like those from the National Institute on Minority Health and Health Disparities, thinking about really the multi-dimensional levels and domains of influence on health disparities. So this has been really interesting work, thinking about sort of the nitty gritty of day-to-day work and how these things might manifest. And it is ongoing, but in this qualitative study, again, we've used some of those frameworks, compared data from high and low performing hospitals, and we're early in this analysis, but some potential drivers that are coming out of it are outpatient care access, differential sort of communication and engagement, especially in languages other than English, differential family engagement around preoperative planning and post-op care, and implicit bias amongst providers. And so some potential promising interventions include standardized protocols and communication tools. At the institutional level, thinking about, and many hospitals have and now have leadership teams that are thinking about disparities and institution-wide interventions around things like understanding implicit bias, and trainings to address those things. So you'll see, like, only a small part of this list of promising interventions are the more common things you see in QI, like protocols and pathways, and the other things are sort of much bigger and not commonly seen. And I think a reflection of that lens. And then this is a screenshot from dashboards they've developed at Seattle Children's Hospital. They are further along this continuum of really integrating equity-focused QI work. So for all of their core kind of quality and safety measures, they disaggregate these and compare subgroups to their overall mean performance or best performing group, and track as they do QI in real time how things are changing. And with folks at Seattle and the team we've been doing safety work with, we recently put out this article just thinking about how how we reference performance in the quality and safety world. So in order to examine, for instance, a construct like racism, you might use white race as a reference. Alternatively, you could use the mean performance and have that kind of be your target. And then lastly, we sort of did an analysis here where we said for each measure, we just pick out the very best group, how they do, and that's the target because that's an achievable target we can achieve for everybody, regardless of sort of which subgroup it is. And then the last thing I'll touch on is, again, that core principle of addressing social determinants or social drivers of health. So a lot of great work happening locally, but again, the Centers for Medicare and Medicaid a few years back started a really large initiative called Accountable Health Communities, where they're having health systems really prospectively test different ways to address social drivers of health, from screening for social risks like food insecurity and housing instability, which we've widely rolled out, to referring families that screen positive for said risks to community organizations, to providing more high touch sort of coaching and navigation, helping families navigate those community resources, all the way to like the health system directly financially supporting and aligning with community-based organizations that are really important to their patients. So this is a continuum that we are on, that all health systems are on. And again, a lot of great work happening here, thinking about what these interventions should look like, how effective they are, and how to optimize their impact. So just to close, sort of the main takeaways that I want to make sure people have from this time is that equity in healthcare quality and safety requires an explicit focus on both goals in tandem. That equity-focused QI really necessitates engagement of broader partners to understand the drivers and map those drivers and interventions accordingly. And then key steps include detecting those disparities, understanding the drivers, and designing interventions with those drivers in mind. And pairing this work does require more resources, but we find that most of it is successful in improving both quality and equity if done intentionally, and has been feasible. So I will pause there and just take any questions.
So I guess one of my main take-homes then is that in any considering that many of our trainees are required to be involved in QI projects, meaning that there are a lot of QI projects going on at any one time, and are there toolkits or resources available for people who are starting out and designing their QI to make sure these considerations are being made? And are there interest groups here that people can reach out to make sure that they're appropriately addressing disparities concerns?
Great question. So as I mentioned, I think, again, this work is nascent. So said toolkit is, like we have IHI toolkits, et cetera, do not exist to my understanding. I am writing grants right now to develop and test said toolkits with CHA and folks. For our resident project, though, I will say it's happening because dedication and passion around these causes are strong. It's happening in a siloed way as is. So last year, so I help sort of oversee and coach our resident primary care clinic projects, for instance. And I bring this up sort of early along the way. And both projects last year did, both the clinic pod projects last year had an equity lens to them and looked at disparities. As a health system, we've developed a lot of infrastructure for doing so. But I think these next steps, again, are less paved. So I was really impressed actually with last year's, I think it was the San Francisco General Group. They actually called patients to understand drivers of like non-compliance with well child visits, for instance, and disparities in those. And those are the kind of things that sort of need to happen to understand. But I did reference, some of these core principles. The article from Seattle shows illustrations of how you might look at the data. So there's a handful of helpful articles to sort of guide the way, especially on the detection side. But I think the understanding side is still very poorly defined in terms of like a toolkit.
Great talk, Suni, and so much progress in a very short period of time, because I remember only a few years ago asking in the adult side, are we collecting any data of even just what are the identities, self-identified statuses for our patients? We made progress, but still a lot to go. I was wondering whether you were able to disclose where we sit as an institution on that high quality, high equity versus high quality, low equity.
Yeah, it's a great question. We don't participate in the database we used for that particular analysis. So the Centers for Medicare and Medicaid have only, I think just last year, mandated that we stratify reporting on their core set of quality measures, things in the adult world like 30-day readmissions. They haven't yet defined. So we define internally what is high and low performance. They haven't yet even defined that to then take the step of paying for better equity performance. But as they do, which they do intend to do, we'll start to get some signal of that. And I'll just say, like, it's very complicated, right? Because there's very little public reporting in the pediatric world compared to adults. But even in the adult world, the measures don't always travel together. So I would say the disparities may not travel together either. So you may see that in sort of cities where there's more stark disparities, something like 30-day readmission you'll see disparate outcomes, but then the things that happen in the hospital, you may not see as big disparities about, so it's very tricky. But I think, to answer your question, I don't know where we sit as an institution, but the infrastructure is sort of growing and moving in that direction to know soon.
It seems to me that since it's one of the big priorities of our department's strategic plan and vision, that it behooves us to know where we stand and then work towards that.
Right. Yeah. No, totally. And it's also really touchy, because if you're an institution that serves a lot of underserved groups, you're going to look worse potentially too. So, there's like Naomi Bardock does some work right now around incorporating social risks into pay for performance measurement, because there's been a backlash against those kind of comparisons when certain hospitals serve a group that's by definition at higher risk. And so they're going to perform worse, so it's a very touchy thing. So everything we're doing in that comparative analysis is all like de-identified. And even as even our interviewers and interviewees, they don't know the performance of that site for that reason.
So thank you very
Of
much.
course. Thank you all. Have a wonderful holiday and Happy New Year.